So today we have a discussion on diaper dermatitis. Before beginning the presentation, we should understand that diaper dermatitis is not a diagnosis per se, but a very descriptive umbrella term which includes a range of inflammatory skin conditions. When the parents come with a child of diaper dermatitis, what questions are we going to ask? The onset and duration of rash? What are the areas involved? What is the cleansing routine which the parents are usually following? Is there any history of topical or oral medication? And are there any other complaints? Etiopathogenesis. It is an interplay of intact skin, compromised skin, and diaper dermatitis. Activating factors like skin hydration, increased exposure to urine and feces predisposes the intact skin to a compromised skin. From here, the induction takes place. Due to the constant irritation and friction, the increased enzyme activity, and secondary microbial infection, it leads to diaper dermatitis. If at this point caregiver intervenes like regular changing of diapers and medical treatment, we can reverse it and it will lead to an intact skin again. Now the differential diagnosis can be divided into eczematous, nodular, vesicobullous and verrucous. In this presentation, we will be focusing more on the eczematous type. Now when the child comes with diaper dermatitis, you first look for the site of involvement. There can be two things at this point. Only diaper area is involved or diaper area and other sites are involved. Now if the child presents with only diaper dermatitis, you look at other sites. If only perianal involvement is there, think of streptococcal perianal dermatitis. Second, you look for skin folds are involved or not. If they are involved, then it's probably intertrigo. If you cannot distinguish if it's involved or not involved, think of allergic contact dermatitis. But if skin folds are spared, it is irritant contact dermatitis. Now let's begin with irritant contact dermatitis. In the figure given, we can see classical sparing of intertriginous areas. Now let's see an image. The image shows a glazed confluent erythema primarily involving the convexities of the napkin area and relatively sparing the intertriginous areas, which is the hallmark of irritant contact dermatitis. Why does this happen? This is attributed to contact of skin with proteolytic enzymes in the stool and the irritant chemicals which is used to wash the areas. There are other morphologies also which are present like tight dermatitis, which is nothing but a macular eruption, a band-like macular eruption and confined to the margins of the napkin areas on the thighs. The second one is jacket erosive dermatitis, in which punched out papulo-erosive lesions are present on the buttocks. These ulcers have also been referred to as ammonical ulcers, and in male infants, ulceration involving the glans penis and urinary meatus may cause discomfort or difficulty in urination. Now moving on to perianal pseudoverrucous papules and nodules. It is a distinct reaction to severe irritant contact dermatitis in which history of stool or urine incontinence is present. What will we see in the morphology? We will see an erythematous verrucous papules and nodules over the perianal region as we can see in the image given. In allergic contact dermatitis, the figure given shows that there is classical involvement of the convexities of the buttock as well as the lower abdomen and genital area with no sparing of the intertriginous areas as we saw in irritant contact dermatitis. It begins as an erythema and small vesicles which rupture leading to an eczematous eruption. Site we've already learned about. And etiology is topical medications, adhesive resins, and fragrant wipes. Intertrigo. It is an inflammatory process where skin rubs against skin folds of the groin, posterior thighs, intergluteal cleft. Seen in overweight infants. The morphology which we can appreciate in the slide is sharply marginated erythematous scaly plaque with pustular-vesicular satellite lesions with a diagnostic hallmark of Candida intertrigo. Diagnosis can be confirmed by microscopic examination of potassium hydroxide preparation, which can be taken from scrapings of the periphery of the rash or any fresh papulo-pustular lesions. Now, streptococcal perianal dermatitis In this, there is sharply demarcated bright erythema in the perianal region. It is associated with perianal itching, burning, and pain during defecation. The causative organism is said to be Streptococcus pyogenes. Diagnosis can be made by cotton swab bacterial culture from perianal skin. And treatment of choice is oral penicillin for 3 weeks. Topical steroids can be applied. Now, if apart from diaper dermatitis, other areas are involved, then look for scalp involvement. If there is no scalp involvement and there is a triad of alopecia, diarrhea, periorificial eruption with acral eczematoid eruption, then think of acrodermatitis enteropathica. If scalp involvement is present, then look at the types of lesions. If we see sharply demarcated salmon-colored plaques with yellow greasy scale, other sites involved are face posterior auricula and axilla, no pruritus, then think of seborrheic dermatitis. If sharply demarcated erythematous plaques with silvery white scales, nail pitting is present, and there is history of non-responsive to topical steroids, then think of psoriasis. If we can see an erythematous papules, nodules, ulcerations, petechiae, plus minus bone pain, think of Langerhans cell histiocytosis. Now seborrheic dermatitis. As we've already learned that it is sharply demarcated salmon-colored plaques with greasy yellowish scale. Rusting and weeping can be present. Other sites involved can be face, flexural areas including axilla, neck, post-auricular folds, and umbilicus. No pruritus will be present. Treatment is gentle cleansing and topical. In psoriasis, we will see a sharply demarcated erythematous plaque with little or no scale due to the constant hydration under the napkin. We can also see presence of classical psoriatic lesions with silvery white scales elsewhere on the body and the presence of nail pitting. Diagnosis is made by biopsy and treatment is topical corticosteroids. Acrodermatitis enteropathica. In this we see a classical triad of diarrhea, alopecia, and periorificial acral vesicobulous eczematoid eruption. The napkin area is involved, the acral area is involved, and the periorificial area is involved. Other characteristics include failure to thrive, photophobia, diarrhea, alopecia, and paronychia. Happens due to zinc deficiency of ZIP4 or ZNT2 mutation. Treatment is zinc supplementation at dosage of 3 mg per kg per day. Now, which disorders present same as acrodermatitis enteropathica? Biotin deficiency, essential fatty acid deficiency, cystic fibrosis, and organic aciduриas. Langerhans cell histiocytosis. In the image given, we can see erythematous and eroded papules in the neck folds, inguinal creases, and trunk with associated crusting. The classical presentation is seborrheic dermatitis-like eruption with erythematous papules and eruptions. Palms and soles are involved. Usually presents age group less than 1 year. VRAF V600E mutation is present. There are 4 types: acute, chronic, progressive, and benign. Diagnosis is made by biopsy, in which we will see infiltration of typical Langerhans cells. In the treatment where skin is only involved, we can do observation, mild topical steroids, topical tacrolimus, and systemic like vinblastine or vincristine can be tried. Now, this is the presentation of Langerhans cell histiocyted in skin of color showing crusted and petechial papules in the seborrheic dermatitis distribution in a child. Now, management. First, identify the cause of dermatitis. The primary goals are keep the skin dry, protected, and infection-free. We need to counsel the parents for frequent diaper changes every 3 to 4 hourly, gentle cleansing with a moisture soft cloth or fragrance-free diaper wipe, exposure to air whenever possible, and minimal to no cleansing is required after urination only. Now let's learn about the ABCD rule in diaper dermatitis. The A stands for air. The diaper should be left open as much as possible when the infant sleeps to allow drying of the skin. B stands for barrier. Zinc oxide base, petroleum barrier preparations are the mainstays of the therapy. C stands for cleansing and anti-candidal treatment. Gentle cleansing with plain water or unscented gentle cleanser is recommended. Avoidance of friction or rubbing and a topical anti-candidal agent can be tried. D stands for diapers. Diapers should be changed as frequently and as soon as after soiling. Thank you.